Hello everyone. Hope you all had a very joyous and sparkling Diwali and wishing you all a very wonderful year ahead. Today we'll be discussing some cases of neurenteric cysts of the central nervous system. The outline of today's talk includes few case studies, clinical features, imaging findings of the neurenteric cyst and its differential diagnosis, macroscopic and microscopic findings, the immunoprofile and prognosis. This is a case one of a 43-year-old woman who presented with behavioral changes for last 5 days. She underwent a MRI which revealed a large thin-walled, fairly well-defined cystic lesion which was extraaxial and approximately measured 8 into 7.5 into 4.5 centimeters in the left frontoparietal region. This lesion was hyperintense on both T1 and T2 weighted images, showing no restriction of diffusion. This case was operated by Dr. Ishtiaq Ansari, a neurosurgeon from Sambhajinagar, and this is the gross which we received in our lab. The histopathological diagnosis was quite straightforward, and you can see this is a benign cyst lined by tall columnar mucin secreting epithelium with presence of goblet cells within, and the cyst wall showed presence of few congested blood vessels, and it is fibrocollagenous. So it's a straightforward diagnosis of neurenteric cyst type A of the left frontoparietal region. Now this is the second case of a 7-year-old boy who presented with right upper limb weakness and shoulder pain. The MRI revealed a well-defined lobulated oval intradural and extramedullary lesion which was eccentric cystic lesion in the right anterolateral aspect of the cervical cord at the level of C3 extending up to C5 that approximately measured 2.8 into 1.9 into 1.2 centimeters. Now this lesion was hyperintense on T2 weighted images and hypointense on T1 weighted images, and on T2 the walls appeared smooth and hypointense. Now this case was operated by Dr. Aniruddha Mohite, neurosurgeon from Kolhapur. The histopathology again was very typical. It was a neurenteric cyst type A, and you can see this is a cyst wall lined by tall columnar mucin secreting epithelium at places showing hobnailing with basally located nuclei, and the cyst wall is fibrocollagenous and showed no presence of any other structures like glandular structures or other lymphatic channels. So this is again a neurenteric cyst type A. Now case 3 is a baby, a 3-month-old boy who was brought by parents saying the baby had irritability, excessive crying, seizures, and also the baby presented with signs of meningitis. Now his MRI revealed a well-defined predominantly cystic lesion within the upper dorsal canal at the level of D2 to D4, measuring approximately 9 into 10 mm. It showed internal low signal intensity and moderate canal stenosis and short segment cord edema. So this case was operated by Dr. Arihant Patil, neurosurgeon from Sangli. This is what cystic structure we received in our lab. And when I received the slide on my table, I was quite surprised to see. In fact, I called my technician to see whether there was any mislabeling, because the cyst showed typical gastric oxyntic mucosa, and there were presence of nice, you can see these parietal cells with dense eosinophilic cytoplasm, and even presence of this muscularis mucosae. So this was a neurenteric cyst type B. Now this is a fourth case which was operated by Dr. Datta Prasanna Katikar from Solapur, and this is a 28-year-old lady who presented with weakness of both the hands and lower limbs and had difficulty in walking and tingling numbness in all her four limbs. On examination, she showed hypertonia of both the lower limbs, hyperplexia of both the lower limbs with power grade 4. There was gross ataxia while walking. Her MRI revealed an intradural extramedullary cystic lesion that measured 1.8 into 1.3 centimeters in the anterolateral part of the cervical cord at the level of C6, C7. A video shared by Dr. Katikar sir for the neurosurgeons here, as this case was operated by an anterior approach. So this is Dr. Katikar sir's message for the neurosurgeons. Spinal anterogenous cysts are intramedullary and anterior to the cord. These are usually operated from the posterior approach. As the spinal cord cannot be manipulated much, we are able to excise it only as much as possible. That is, some residual wall will be present which may lead to recurrence. This case was done by anterior approach after corpectomy. We had superior unhindered access to the cyst staring at you. This offered a great opportunity for a sure shot total excision of the cyst in order to avoid recurrence with zero handling of the cord. There was more than adequate space for instruments and watertight closure of the dura by this approach. Thank you very much, Katikar sir. So we received slides and block for in our lab for the second opinion and immunohistochemistry, and this was again neurenteric cyst type A of the C6 C7 level intramedullary cyst. So I will be discussing immunohistochemistry in general for all the cases. So the neurenteric cysts are EMA positive, pan-CK positive. CK7 is expressed in the lining of the foregut. So CK7 is positive in the cases, and CEA is most supportive to the diagnosis, that is carcinoembryonic antigen, and the Ki67 proliferation index is very low. So coming to the discussion part, neurenteric cysts are uncommon congenital lesions arising from the abnormal connection between the endoderm of the enteric tube and the ectoderm of the primitive neural tube. The other common terminologies used are neuroepithelial cysts, enteric cysts, enterogenous cysts, respiratory cysts, and the bronchogenic cysts. Now these cysts can occur at any level of the central nervous system but are more commonly found in the spine than the brain with a ratio of 3:1. Now the cysts found in the spine are more common in the lower cervical and the upper thoracic regions, and these represent approximately 0.3 to 0.5% of the spinal tumors. Most of these cysts are found ventral to the spinal cord, and these are intradural and extramedullary cysts. Coming to the intracranial cysts, 70 to 75% of intracranial neurenteric cysts are midline, infratentorial, and extraaxial in location. Most are anterior or lateral to the pontomedullary junction, and only 25 to 30% are found in the supratentorial region, that is suprasellar or the cerebral hemispheres. These are usually found in the first 2 decades of life and show more of male preponderance. Now, the clinical features depend mainly on the location. So, the intracranial cysts, as we discussed, are found mainly in the midline. They may be anterior to the brainstem or the craniocervical junction or the CP angle or the fourth ventricle. So, they will present with the clinical features. Uh, Approximately 50% of spinal neurenteric cysts are associated with skeletal deformities, including scoliosis, spina bifida, Klippel-Feil syndrome, syringomyelia, or other defects of the GIT, such as duplication, fistulas, and atresia. Intracranial neurenteric cysts are uncommon and have very rarely been associated with the skeletal. Coming to imaging findings in general, the neurenteric cysts are oblong, non-enhancing, slightly hyperintense to the CSF. On CT scan, these are hypo to iso to hyperdense, usually with no calcification. On MRI, these are almost iso to hyperintense to the CSF on T1 weighted images, and 90% show hyperintensity to CSF, and only 10% are hypointense on T2 weighted images. And usually these show no enhancement. However, a mild rim enhancement may be present in some cases. So the differential diagnosis on imaging, it could be an epidermoid cyst. These are white or epidermoid cyst, and they are usually hyperintense on T1 weighted images and usually restricts on diffusion weighted images. The second is the dermoid cyst. It will show presence of fat and often calcification is present. Third is the arachnoid cyst. These have CSF like on all sequences. And fourth is the cystic schwannoma. However, these enhance very strongly and usually are not midline. Then next we should take into consideration is the other endodermal cysts, that is the Rathke's cleft and the colloid cyst, which are excluded by location. And the last and the rare one is the Ichordosis physalifora. This is a notochordal remnant and it often involves the clivus. Coming to the intraoperative and gross findings, neurenteric cyst is basically a thin-walled cyst which is filled with fluid. The inner aspect of the cyst is smooth, and the physical appearance and the viscosity of this fluid or the liquid may vary. Now it may appear milky, yellow, brown colored, or may even have water-like or mucus or jelly-like consistency or viscous consistency. The molecular analysis of this fluid reveals a high protein content with a variable amount. Histopathology. Neurenteric cysts are benign cysts lined by cuboidal to columnar cells. The epithelial layer exhibits feature of gastrointestinal tract or the respiratory lining with or without cilia, mucus glands, or goblet cells. These cysts are also associated with presence of other connective tissue components. Wilkins and Odom have proposed three different histopathological categories of neurenteric cysts depending on the basis of epithelial integration to the basement membrane and or presence of other complex cellular structures. So the type A neurenteric cyst exhibits the simplest organization with a single layer of cuboidal to columnar cells that are associated with the basement membrane, and these cells may or may not show presence of apical cilia. The type B has the features of type A in presence of other connective tissue components such as glandular structures, cartilaginous, or the lymphatic tissue in the histology. The type C is characterized by the cyst, which is lined by cellular component of type A in presence of glial or the ependymal cells. Immunoprofile. So the positive markers are EMA, pancytokeratin, CK7 and CEA positive. Now CK7 positivity is present because of the foregut lining. The Ki67 proliferation index is very low. The negative markers are GFAP and S100. S100 may be positive in some of the NECs. Even special stains can be carried out in NECs because of abundance of goblet cells and mucin secreting cells. Therefore, PAS and mucicarmin is positive. Coming to differential diagnosis of spinal cysts. Now, this could be ependymal cyst, epidermoid, or the dermoid cyst. Differentiating neurenteric cysts solely on the basis of light microscopy from other intramedullary or intradural growth may be challenging. The ependymal cysts exhibit similar cellular morphology with ciliated simple cuboidal to columnar epithelium, and these are GFAP and S100 positive. The choroid plexus cyst expresses vimentin, S100, synaptophysin, and transthyretin. The colloid cyst is usually located in the third ventricle. We need to rule out the other cystic tumors. And the next is the papillary endolymphatic sac tumor, which is usually present at the cerebellopontine angle, and it is within the bone and has more complex architecture. Treatment and prognosis. Total surgical removal is the optimal treatment. However, leakage of the cystic fluid into the intramedullary cavity may cause meningeal irritation, especially more prevalent in the newborns and the infants. So take home message. Neurenteric cysts are benign cysts of the central nervous system affecting spine more than the brain, and these are caused due to the malformation defect. On imaging, these are hyperintense on T2 and T1 weighted images, and they are usually smaller in size. The inner wall of the cyst is smooth and the fluid content may have a variable color and consistency. On microscopy, these are lined by simple cuboidal or columnar epithelium, and there are three types of cysts depending on the cellular components. Coming to the treatment, total excision is the treatment, and if there is some residual, this may lead to recurrence. And these cysts have overall good prognosis. Thank you very much.